In this video, we'll discuss acute respiratory illnesses or short-lived respiratory illnesses that are common in children. Before we get into specifics, let's review some basic assessment for respiratory conditions. First, we always listen or auscultate. You'll find a useful video on Blackboard that reviews lung sounds, both normal and abnormal, with you. We also assess the pattern of breathing. This includes things like the respiratory rate, the effort, and checking to see if there's any positioning, grunting, flaring, retracting, or anything else that would tell us that the patient is working extra hard to breathe. If we are looking for a specific pathogen, sometimes we do cultures or rapid antigen testing. This might help us identify a particular bacteria or virus, for example, influenza or strep bacteria. If we want a better idea of what's going on inside the lungs, we can of course do a chest x-ray to get a visual image, or if we actually want to measure air movement and flow in and out of the lungs, we can do pulmonary function testing. The chest x-ray is useful in these acute respiratory illnesses. The pulmonary function testing is usually reserved for more chronic issues where we're tracking lung function over time. The first respiratory illness we'll cover here today is by far the most common, URI, or upper respiratory illness. This can cover most of our bases, but usually this is what we just call having a cold. So, caused by viruses, easily contagious, and very common in little kids, with a much higher risk for kids in daycare. When we care for patients with an upper respiratory illness, we just provide what we call supportive care. This means we can't cure it. We have no cure for a virus. We have to let the body fight it off. But we'll support the patient and try to minimize the symptoms and their discomfort as much as possible. So for infants, they can't blow their nose, so we do nasal suction. And this is usually with one of those blue bulb syringes. Just a heads up that most babies really hate the bulb syringe and aren't nearly that happy. But at least it demonstrates to you, you squish the syringe, the bulb on the syringe, place it in the baby's nostril, and then let go, rather than placing it in the nostril and then squishing it. That just helps to bring some of the mucus out of their nose and open their airways. Remember that babies breathe through their noses. They don't really know how to breathe through their mouth, so keeping that nose clear is especially important. We can also elevate the head of the bed just a little bit. We don't want them sliding down and getting squished at the bottom of the crib, but if you can tuck a rolled up towel under the crib mattress just to help drain some of the mucus from the back of their throat, that can help them feel more comfortable. We also want to keep the mucus thin so we can humidify the air and encourage oral fluids. We also get a lot of parents who ask about providing over-the-counter cold medications. And for any child under 2 years old, cold medications are just not approved. Even older than that, though, we know that cold medications merely mask symptoms and can actually fool people into thinking the child is no longer sick while they're actually still contagious. So maybe a little bit of cold medicine if it helps the child sleep at night, but otherwise it's a good idea to let everybody see how sick they really are. Unfortunately for infants, some viruses that would cause just a common cold in older children or adults can turn into bronchiolitis. And this is inflammation in the smaller airways. So this is where an upper respiratory illness actually turns into an upper and lower respiratory illness as well. So stuffy nose, cough, absolutely still part of this, but they also get lower respiratory symptoms like wheezing, crackles, and difficulty breathing. The most common virus associated with bronchiolitis is RSV. This is the respiratory syncytial virus, and it most commonly affects infants from 2 to 6 months, but it can really be anyone under 3 years old. If an adult or an older child gets an RSV infection, it just looks like a cold rather than presenting as bronchiolitis. Much like the flu, RSV does have a season, and it is in fact the same season from approximately October to about May, depending on the year. The reason bronchiolitis strikes younger kids rather than older kids or adults is mostly just related to size. So you can see that an infant airway is just much smaller to begin with. So even a little bit of swelling, 1 millimeter of swelling in those airways, closes this airway to just 2 millimeters. Whereas an adult with an airway of about 8 millimeters, 1 millimeter of swelling, they still have 6 millimeters of airway, so they just don't have that same difficulty in breathing with even just a little bit of inflammation. The signs and symptoms for bronchiolitis follow sort of a coming and then going pattern. So for about days 1 to 3, you start to get sicker and sicker, and then about days 4 to 6, you're about at a plateau, and then days 7 through 14, there's a slow, gradual recovery. The most common signs and symptoms we see are things like runny or stuffy nose, a cough, wheeze, retractions, decreased PO intake, decreased energy, and we can even see fever for a few of those days. It's important to try to get an idea of where in the illness the child is when they present for healthcare, because if they're way back here at day 1 and they're already requiring supplemental oxygen, you know they're going to get way worse, and so we definitely need to admit them for further support. But if they just appear to be struggling just a little bit and they're already here at about day 6, we know we can actually just expect them to improve from here on out, and they'll probably do well at home. In either case, no matter what we decide to do for the child, we need to make sure the parents know to recognize and report any signs of respiratory distress in the infant. In case you haven't personally seen retractions, here's a picture to help illustrate. You see this ridge between the baby's ribs and their tummy? That would be subcostal retractions, where we see the skin sort of sinking in under the ribs. We can also see intercostal retractions, where the skin sinks in between individual ribs and the rib cage here, or supracostal or suprasternal retractions. You can't see it on this baby because their chin's in the way, but you can have the skin sinking in up here along the clavicles or right above the sternum. Just like with a URI, treatment for bronchiolitis is usually just supportive care. The difference is that sometimes the infants really require some intensive support in order to make it through the worst part of the illness, so they do require hospitalization. In the hospital, we can provide supplemental oxygen, IV hydration, and nebulized medications that we don't routinely do at home. Now, there is some controversy about these nebulized medications. Because the children wheeze, for a while, people tried giving albuterol, which is a medication for asthma. But the more we've done research on that, we realize that it's not really effective unless the child does have underlying asthma. Instead, people are now trying hypertonic saline. This is concentrated salt water that helps to draw fluid out of the swollen lung tissues and into the mucus, just to make it easier for babies to clear their lungs of all that gook. Whether they're at home or in the hospital, we're still going to focus on keeping those nasal passageways clear. And again, we can raise the head of the bed and then try to encourage PO fluids if the baby can tolerate it. But usually if their respiratory rate is greater than 60, we hold off on any kind of oral intake just to prevent any risk of aspiration or choking. Of course, ideally, we would like to prevent infants from getting bronchiolitis in the first place. So, of course, the major thing to focus on is hand hygiene. And if we have a child with any kind of chronic illness, chronic lung disease, chronic cardiac disease, who we know will be particularly sick with RSV or bronchiolitis, we also do some self-imposed isolation. So maybe the family will just sort of stay at home, hunker down for those winter months, avoid daycare, avoid play group, any of those places where other children with the virus can spread it to the at-risk infant. The other thing we can do for high-risk infants is a series of injections of a medication called Synagis. That's the brand name, or the generic is palivizumab. And this is about $1,000 per shot, and you need about 6 shots. So you can see why insurance companies might reserve this just for the high-risk infants, including premature infants or an underlying chronic illness or possible immunosuppression. So most insurances do have an algorithm that determines whether an infant meets requirements or not. Of course, even if a child is eligible and will have the entire series of shots covered, it's still a challenge for the parents to bring the infant to the office once a month for 6 months to get this injection while still avoiding exposing them to other germs. So this would be an excellent situation for home nursing if that's available to the family. A lot of parents will ask if their child is developing asthma because they wheeze with bronchiolitis. And we have some evidence that there's a slight increase in the risk that the child will develop asthma as they grow a little older. But we also know that most children who wheeze prior to their first birthday outgrow that wheezing syndrome by their 12th birthday. So there is hope for these parents. That's good news. The next acute respiratory illness we'll discuss is croup. This is also called tracheolaryngobronchitis, if you feel like sounding fancy, because it is in fact inflammation of the trachea, the larynx, and the bronchioles in small kids, typically under 5 years old, although I have seen some older kids with the croup syndrome. The difference is that in children, the whole airway is much smaller and produces this croup-like syndrome, where in older children and adults, the trachea and the bronchioles are much bigger, so we mostly just end up with laryngitis. That's the equivalent older person illness here. Here's a picture to help you visualize where that narrowing is, right here in the neck. Croup does not need to involve any nasal symptoms or a cough. It just is focused right here in this airway. However, it is usually caused by a virus, so a lot of times we do have those associated symptoms. This picture will help you visualize the difference between the adults and the children. If you notice, adults have much more space back here in the larynx and the trachea, where in children it's all much narrower. So any inflammation causes much more severe blockage of that airway. Croup is characterized by a hoarse voice and a barky, tight cough. If you've never heard the croup cough, go ahead and look for it on YouTube or Google and see if you can find some videos. Some people say it sounds like a seal barking. Along with those symptoms, you may have a little bit of a runny nose, maybe a little bit of a low-grade fever. The child just might kind of feel ill, but there's no significant high fever. They're not coughing anything up. Mostly just focused right there on that upper airway. To diagnose it, we usually just diagnose it following symptoms, but if needed, we can even do a neck x-ray just to visualize the narrowing in that section of the airway. To treat it at home, people can try one of two things. One, a hot steamy shower. That helps to open the airway for some children. Or two, cold air. So a lot of times this happens in the winter, and the parents can just take the child outside, breathe the cold air, and the cold seems to help to reduce that inflammation in the airway. If the child, though, is still demonstrating significant increased work of breathing, whether they have grunting, nasal flaring, retractions, or just a really high respiratory rate, we always want them to seek medical attention. Then the healthcare providers have a few other options. The first medication we like to use is called racemic epinephrine, and this needs to be inhaled. This usually works very quickly and works very well. The problem is it only lasts for about 2 hours. So the other thing we can do if needed is a dose of a long-acting steroid, or we can send them home with some shorter-acting steroids that they need to take for a few days. The favorite steroid here is called dexamethasone because it lasts for about 36 hours, so by the time it starts to wear off, the virus has also started to wear off. If very severe, occasionally croup will require emergency intubation. But thankfully, that doesn't happen very often. For the nursing care of a child with croup, your main focus is to minimize agitation. The more agitated the child gets, the more difficult it is for them to breathe, and the more they panic, and then the faster they feel they need to breathe, but they're still having trouble breathing, so you end up in a downward spiral. So as much as possible, keep them calm. So by all means, involve the parents, let the parents hold them, let the parents provide the medication if that works better for the child, and look for the least invasive route for those medications. A lot of times this means the oral route, but I distinctly remember one young man who absolutely refused to take the medication orally, and it became obvious that the least invasive route for him to take his steroid was an IM injection. Just get it in, get it over with, and avoid the fight. However, most kids would prefer to take it orally rather than being poked by a needle. And then, of course, we need to educate the parents about how to care for croup at home and about those signs and symptoms of respiratory distress in a child. It is important to distinguish epiglottitis from routine croup. Epiglottitis is specifically inflammation of the epiglottis. Remember that the epiglottitis is this flap of tissue here at the back of the throat that is designed to close off the airway when you swallow food or liquid so it doesn't go down into your lungs. The problem with epiglottitis is that when this gets too swollen and inflamed, it's too heavy for the muscles to hold up, and it flops over, blocking the airway, making it impossible for the patient to breathe. So epiglottitis is an emergency. The signs and symptoms look a little bit like croup, but much more severe. So it is usually a sudden onset, We usually see a high fever, a severe sore throat, this muffled, funny sounding voice. Some people say it sounds like they have a mouthful of marbles or a mouthful of potatoes. And they can have difficulty swallowing or very painful swallowing, so that as the disease progresses, they'll actually just drool rather than swallowing their own saliva. If at any point you suspect that your patient has epiglottitis, there are 2 things you need to do. Number 1, call for help. We need a provider in there as soon as possible because this can quickly turn into your patient is no longer breathing. And number 2, provide supportive, non-invasive care until that provider arrives. So this might include a little bit of blow-by oxygen as long as it's not bothering the child, keeping them in an upright position to help maintain that epiglottis where we want it to be, and also obtaining all the supplies that you think the provider might need for treatment. Treatment of epiglottitis is immediate intubation. Before that epiglottis has a chance to close the airway, we have a skilled provider, maybe an anesthesiologist or some other pediatric specialist, place a tube down that airway while it's still open. This does, of course, involve sedating the child. We can then maintain that airway open and supporting breathing until we've had a chance to address the infection. Epiglottitis is usually bacterial, so we provide antibiotics. Those are usually IV, just to get the maximum effect as quickly as possible. As the child, the patient, then improves, we can gradually wean off the ventilator, wean off the intubation, and they will be able to finish their course of antibiotics, but we still maintain very careful respiratory monitoring. So if in doubt, if you think your patient might have epiglottitis, don't touch them, don't bother them, call for help, and get all the supplies you think the provider might need to intubate. Okay, pause for a second and review the acute respiratory illnesses we've already looked at. What are the signs and symptoms? What's your nursing care? How are you going to tell them apart? When you feel like you've got a good grasp on the last ones, go ahead and advance the video, and we'll talk about influenza next. I know you've all at least heard of influenza before, so hopefully this is mostly review. It is, of course, a virus that affects mostly the airways, although influenza type B can also cause some GI symptoms like vomiting and diarrhea. I will just take a second to warn you that when people say, I have the flu, make sure you ask a little bit more about what they mean. Sometimes they mean the stomach bug, which usually is not caused by influenza. That's more of a rotavirus or a norovirus or an enterovirus, a different kind of virus. Influenza is seasonal. It affects the U.S. mostly from about October to about May, although that can fluctuate a little bit from year to year. And we know it's droplet transmission and quite contagious. So if people around you have the flu, there's a good shot you're going to get it. Depending on the year, about 10 to 40% of the kids in the USA are affected every year. But the good news is only about 1% of kids are hospitalized. The signs and symptoms. First of all, fever. You have to have a fever if you think you have the flu. Then usually some upper respiratory symptoms like cough, runny nose, sore throat. But it does affect your whole body. So a lot of people are very achy. They have malaise, fatigue. And if it's that influenza type B, you might also have some GI symptoms. Usually we just diagnose a patient based on the clinical picture, but if for reporting purposes or because we really want to be sure, we decide to do a rapid antigen test for influenza, we need a nasopharyngeal swab of the mucus at the back of their throat. So this is not the swab that you do for MRSA that you just sort of put it in the nares here. No, this is a long flexible swab that needs to go all the way back through the nose and actually hit the back of your throat. So if your patient looks comfortable while you're doing it, you're not doing it correctly. It really is a very uncomfortable procedure, but this is where most of the antigen hangs out, so that's where we need to collect the specimen from. Just like with the other viruses we've talked about, treatment is mostly focused on supportive care. So Tylenol or ibuprofen for fever, for aches, maybe a little bit of cough drops, cold medicine for the sore throat, and then a lot of rest. In our culture of busy, work, go to school, a lot of people return to work or school too soon, and they really just need to stay at home, rest, and not contaminate other people. We do have an option for Tamiflu. That's the brand name, or oseltamivir. This is an antiviral medication that can shorten the duration of your influenza symptoms, but sometimes it's only about 8 hours shorter, so 4.5 days instead of 5 days of having the flu. It can also cause GI symptoms as a side effect, so some people just really hate the Tamiflu and choose to avoid it. We do specifically use it if we have a reason to believe that that patient could possibly die from influenza, like immunosuppression or an underlying respiratory illness. It also has to be given within the first 48 hours of the influenza virus in order for it to do anything. The only time hospitalization is required is if, for whatever reason, the patient's not able to maintain their respiratory status or their hydration at home. So usually this is oxygen or other respiratory support and IV fluids. With most versions of the flu virus, it's only the very young or the very old that ever require hospitalization. Of course, the best way to deal with the flu is to just prevent it in the first place. So I know you all got your flu shot, but let's take a second to make sure you understand how that works. Usually the flu shot contains 3 to 4 strains of the virus, and the challenge is that the scientists have to predict a year in advance which strains to put into the flu shot because the virus is constantly morphing. So they look at what strains have been affecting other countries around the world and make their best guess. This is why the flu shot works better some years rather than others. We also know that for kids, the nasal spray just doesn't seem effective in preventing influenza. So we really do want the flu shot for our young kids. One strain of the flu that caught us off guard about 10 years ago was the H1N1 flu. So you can see that in 2006 to 2007, we only had a few influenza deaths reported. Same thing, 7-8, 08, 09. But between the 09 and 010 years, these purple lines are pediatric influenza deaths caused specifically by this H1N1 flu. You can see that it was just significantly more deadly in our pediatric population. So this is why we do track it. We do recommend the flu shot. The good news is that this year, we're not seeing the same level of pediatric deaths. So this is exciting. We're still, of course, getting flu data from across the country. But as of right now, it actually looks like a pretty slim year for our kids, which is great. Of course, we do know that flu activity is spiking around the country right now, but the flu deaths have not spiked. So this is a good year for us. We're just going to continue to promote hand washing, cough hygiene and getting those flu shots for our patients, and hopefully this is a trend we continue to see every year. Okay, the last acute illness we're going to cover is pneumonia. And pneumonia is where you have a collection of fluid or mucus or bacteria or any foreign body really in the alveoli in the lungs. So you can see here that normally we have nice air sacs in the alveoli. This is where exchange of oxygen and carbon dioxide takes place. But with pneumonia, each of those little air sacs get filled up with fluid or mucus or bacteria or all of the above. And then we don't have the ability to exchange gases in there. This will show up on a chest x-ray as this white, the term we use is consolidation. We can tell that there's something making that lung solid. Here's nice, black, empty, airy, healthy lung, and here's the white collection of gunk in the pneumonia lung. So the signs and symptoms for pneumonia, just imagine having all that gunk in your lungs and an infection, and how would it turn out? So infection, we do usually have a fever with it, a cough, and that is a productive cough, meaning you cough stuff up. That sputum can also be interesting colors like greens or browns, so not very pleasant for the patient. They often complain of chest pain, or that can even sort of refer down and become stomach pain in a young child, or even vomiting, nausea. And then, of course, when you listen with your stethoscope, you either hear just decreased breath sounds because there's no air moving at all, or we'll hear crackles because we hear all that fluid bubbling around when the patient takes a breath. Now, there is a type of pneumonia called walking pneumonia. And that's common in young kids. And they don't usually have a fever, but they will still have the productive cough, maybe some stomach pain, maybe some vomiting, and you'll still be able to hear their changed breath sounds when you're listening with your stethoscope. If all of these symptoms aren't enough to convince us that the patient does have pneumonia, then of course we can do a chest x-ray or a sputum culture just to help confirm that diagnosis. Then treatment for pneumonia focuses on the cause and then supporting respiratory status. So since it's usually bacterial, we usually need antibiotics. Walking pneumonia gets its own special kind of antibiotics, and occasionally we can also have viral pneumonia. So of course we wouldn't use the antibiotics for viral pneumonia. Otherwise, we're focused on supporting the patient through all the symptoms. So maybe pain management if they are having a lot of pain, hydration, maybe some medication for nausea if they need it. And then a lot of times we require supplemental oxygen or even intubation for severe cases. It's also possible for patients to develop a pleural effusion, which is a collection of fluid around the lung, or even an abscess within the lung. In those cases, the patient will require a chest tube to drain that fluid and/or abscess so the antibiotics can get where they need to be and help fight the infection. Of course, if a patient does require a chest tube, they will be hospitalized as long as that's in place. As long as the patient is not requiring any respiratory support, however, they can usually take their antibiotics at home and just rest and recover there. Okay, to wrap things up, let's just review real quick. We reviewed assessment of the respiratory system, and then we moved into our acute illnesses, like the upper respiratory illness, bronchiolitis, routine croup, or laryngotracheobronchitis, but we were careful not to mix it up with epiglottitis. Then we covered influenza, and finally, pneumonia. Make sure you can tell the difference between the symptoms of all of those, and then make sure you're clear on some of the main treatments that we use to support the patients who have these conditions. As always, let me know if you have any questions and before you move on to the next video.